Ahead and get started.
Okay.
This is Becky Royer, and I am the coordinator for the MB-QUIP project for the State Office of Rural Health, and just want to thank Joyce Fillenworth and David Conrad for providing the funding so that we can put on the education programs for the critical access hospitals. And in this particular part of our contract is to help you grow your swing bed departments, and this has really been an exciting year for swing beds. So we really want to thank you for all the work that you've done throughout the state and all of the extra efforts. I also want to thank Allie Orwig for helping me host the Zoom platform. Allie's with the Indiana Rural Health Association, and so David and Joyce also provide funding for her to be able to do that with larger groups. I do want to remind everyone that the Indiana Department of Health is providing a learning collaborative on trauma-informed care. The first session is tomorrow, July the 14th, from 12 to 1:30. I just distributed a recording to all of the swing bed participants to learn a little more about what the collaborative is about. It originally started with a collaborative that the Indiana Department of Health has routinely done and is part of a requirement for some of the federally funded clinics throughout the state. But for this particular topic, they wanted to open that up to critical access hospitals, since trauma-informed care is such an important part of what all of our critical access hospitals do every day. So if you didn't see that recording link, why, let me know. There's no formal data collection that's required from the critical access hospitals, while there is for some of those federally funded clinics. It's more for information and building knowledge and giving you the information that you need to implement trauma-informed care in your hospital. Dr. Perry is an important national expert that is a part of the planning group and the education group. Dr. Perry wrote a book along with Oprah that some of you may have already read. It's called What Happened to You. It's a wonderful book. It's very insightful, and I think you will find it well worth the read if you get that opportunity. If you're part of the collaborative, there will be some coaching sessions in between those learning sessions that are being conducted. And so if you want to learn more information, reach out to me and I will be glad to get that information to you, and want to thank those that have already expressed interest and will be joining us. But I think it's a good opportunity for everyone. It's also a topic we all struggle a little bit with, how to accurately handle and how to best support your patient. So we'll be learning more about that then as the next few weeks go on. So today's presentation is our monthly education webinar where Kerry Dunning, our swing bed consultant, provides some good information for us, and just continuing to build, refine, and make sure that the swing bed programs are very compliant with all of the requirements. So without further ado, I will turn it over to Kerry for today's discussion.
Hello.
Thank you very much. I'm glad to hear about the trauma-informed care training. It's really, really critical, and maybe even more so now, even though the rules for TIC came out a couple of years ago. Because of the pandemic, the number of people that were isolated, either lived alone or had health issues during that one big 2020 bolus that we've had, it is seriously more on the front burner. And a lot of the nursing homes that are getting reviewed just by state surveys and so forth, they are looking at our depression scales, how we are measuring depression, cognitive issues too, but depression. So just keep that in mind, and any training right now is really, really going to be helpful. So it gets from talking about it into real life, working with your staff and your patients for that matter. So along the same lines, I have something on the screen that when you get your taping, I think is when Becky's going to send it out. I've attached a QSO, which is just a government document. If you look at the top of this one's 113 pages long. And it's about emergency preparedness. And Appendix Z in the State Operations Manual is the area where they have the emergency preparedness rules. And this list right here, which is on page 2, so you can look at it and get a general idea when you get your copy of it, is a list of the things that they have updated. If you don't know about the State Operations Manual, you really should. It is for skilled nursing and thus for our swing bed programs. For Appendix W in the State Operations Manual is where you find the critical access hospital rules as well as the critical access hospital swing bed rules, and they do update them. And the way you're going to know that something has been updated these days is anytime you see something in red like this, you see the please note in bold, and then anything in red are changes that have come to that document. And then as they update it again, they take out that red and add in more red. And if you go all the way through 113 pages, you will see there's a fair amount of red in this. Now, having said all that, I do want to remind you that you are in a hospital setting, which means you already have emergency preparedness plan. The only thing that you have to pay attention to and make sure that your hospital staff that is dealing with this topic realizes that you are different licensure. So if there is something that requires us, for instance, to transfer patients to another setting during an emergency, then it's important that they understand that this isn't a hospital to hospital. This is going to be a swing bed to a skilled level of care. So you need to make sure that the language in your emergency preparedness plan looks specifically at skilled rules. So when you're reviewing this, you want to really look at 483.73 with your emergency preparedness team within your hospital because they're going to know how to do the hospital piece. And it's not that different. You just want to be able to follow those rules. So that's sort of my first warning of the day. And then we're going to kind of go, if I can find it again, and go through some slides. Now, what I am trying to do with this, I'll move some things here. Is we need to move from just building our swing bed programs to protecting our swing bed programs. And by protecting, I mean, as you build and your hospital has some dependency on your swing bed revenue, whatever that might mean. I've got programs in critical access that are running an average of 21 swing beds. So that's heavy dependence on the revenue coming from swing beds. I have others that are running 2 and 3 swing beds. So wherever you are is perfectly fine. It's for your decision internally for you guys to decide what the mix of acute and swing bed needs to be. But we do really need to be in compliance. And I'll deviate here for a second. One of my favorite things to do when I travel is take pictures of signs because you see the weirdest things. And this one just struck me because I was out actually on a mountain road and saw that, and it sure looked like they were directing me to run toward this tsunami instead of away from a potential tsunami. But just know that's not a sign that I see very often in the U.S., but you see in South America a lot, and you see in New Zealand and Australia a lot. So just for fun. All right, so the reason this is sort of a hot topic right now is just a couple of weeks ago on June 21st, the feds issued a whole lot of warnings all on one day. And when we added them all up, and I mean various consultants and others working in the field were looking at all of it, this was the list of the things that they updated. And you see from that what's in red that all of it has to do really ultimately with your documentation. So the first one, your MACs, that's your fiscal intermediary. That's the group that pays you for Medicare. Medicare doesn't pay you directly. They pay through the Medicare Administrative Contractors, or the MACs. I think, Becky, it is WPS in your region, isn't it? Yeah. So it's Wisconsin Physician Services is your MAC. And what they are looking at, you see documentation there in the second one. Well, they're looking for cert and recert issues, which we're going to talk about in a second because everybody's doing that. But their wording individually is that the level of care is not supported. And so we will be talking about that today. If you look at the RAC auditors, and they are back out. We used to say recovery auditor contractors, I think, which is where the RAC came from. They shortened it. I don't have no idea why. It got under somebody's skin and they went to recovery auditors. But you probably know them as RAC auditors, and you will see improper payments. Improper payments again come from how was the skill level supported, and where was the documentation for it. RAC auditors are post-payment review. So what that means is you've already gotten paid, you've filed the claim, it's been paid, and now they're going back and looking at those claims and matching the claims up, and ultimately can match that up to your documentation. This cert is not the physician cert. This is a different cert, comprehensive error rate testing. And this one's an interesting one because you do not see them directly. Basically, they are reviewing the MACs, in this case, WPS, to see if they paid you correctly. And the way the MACs had to pay you correctly is they caught the lack of documentation or the wrong level of care, whatever. So they are now the auditor to the MACs are the auditor to you. So, welcome to the federal government. There is an area called a supplemental medical review contractor that your billing department will know about. We don't usually have to deal with on the clinical side directly. Again, looking at improper payments. Meridian, which is another MAC, actually oversees the entire program for the U.S. at this point. Instead of breaking it up by MAC, you need to warn, because this just came out on 6/21, warn your billing department if they don't already know that if they are getting a supplemental medical review, it will come to them in a green envelope. So that's the way they will be able to tell. They do not need to toss that aside. They need to pick it up pretty quickly and look at it because there's time limits for responses. And the last one that's back active is the Unified Program Integrity Contractors. They look at fraudulent claims. This doesn't hopefully get any of us on this phone call. They're the ones that go after when you see like a home health agency has criminal charges against it because they were billing for charges they did not provide. In other words, they had said a patient was getting 10 visits and they got 1 or whatever. So fraudulent means fraudulent, that what they billed for was not delivered. So hopefully none of us are in that bailiwick, but that's a pretty good list of things going on. So you've only heard me say this 1,000 times, so I won't go into it in depth. But the physician cert's easy picking for them, guys. If it is not completed correctly, if you can't find it quickly in your files, you should be testing yourself before you submit claims to make sure you can find it. Because if you can do it before you close your chart, you certainly can get signatures and dates on that from the physicians and so forth. But the physician cert and then any recertification, which the first ones do on or before the 14th day and the others after that, up to 30-day increments after that 14th day is signed. So if you sign on day 12, let's just say that makes it June 12, then 30 days from June 12, by that date, you have to have a re-cert. The reason I'm bringing up research a little more than normal is during the pandemic, we had people staying longer with us than what was our normal swing bed stay. I still have swing beds that have had patients 30 to 70 days right now. I had somebody go as far as 89, but that person's discharged because they got long haulers that either the nursing home still hadn't opened up, for skilled stays and or didn't feel like they could take care of the a lot of them have pulmonary issues and didn't feel like they could care for them at the level of care that was needed. So just remember the cert can go out to 100 days total.
Kerry?
And remember, yes.
I was going to say,
yes.
Stephanie Laws from Union Hospital Clinton, she just chatted in that they just had an MSP audit. Stephanie, I don't know if you want to unmute and share anything about your audit or...
Yeah, sure. So I just want to, again, give a hats off to the relevance of these swing bed discussions. And I think, Kerry, you might remember that when we came in and we did you know, that high level 30,000 foot view of the swing bed program, and then took some deep dives. MSP was one of those items in which we pulled some individuals into the board conference room, and there was a lot of eyes rolling around and looking at each other, not knowing what exactly was happening. So I don't have the results of the MSP audit just yet. We did send off all of the requested charts as well as our certified mailer. So it was all done remotely. And so we're just waiting on those results. We feel pretty good about it because after you had left, we had put in some safeguards as well as conducted our own internal audits and review. And we had kept that in place. So I will make sure that I communicate with Becky and let her know how we did. But again, as you were listing out your list of auditors and reviewers, MSP, yes, we did.
Yep. And Stephanie, I will not forget that day because that's the most MSP issue that I have ever run into. And I think you got it right away. Your business office person who was on the hot seat at that point really got it. I got it. I don't think anybody else in the room understood the relevance of that. So the issue is MSP, for those of you that are clinical, is done at registration and admission. So usually when it gets to the clinical side, we're not as aware of it. And it is a tool to determine whether Medicare is the primary payer or a secondary payer. Easiest example is a car accident. Usually the auto insurance would be primary and Medicare would fall to secondary in that example. And it is absolutely required. And there is information that must be completed. And there should be hard stops in your computer systems, because we used to do this on paper. Stephanie, are you doing it on paper again? Or are you back to trusting a computer system?
It is currently electronic, and we are also in the process of converting to our own health system singular Cerner platform. So we actually have a all-day I as administrative team has an all-day meeting on Thursday regarding rev cycle. And so they're supposed to go through all of those changes, and guess what's on my radar?
Yeah, yes. Well, and then just for everybody else, Stephanie, because you learned that very clearly. And I think, Stephanie, you were fairly new at that hospital at that point too. I mean, it was like a double whammy day.
Yeah, I started in 18, and I think our conversation was in 19.
Yeah, it was pretty quick after you got there. So the importance of the MSP, there's some questions there should be hard stop on. All the information has to be accurate, like any other form going to the federal government. But in this case, there are two things that are really important for determining whether Medicare is primary or not. And the first one is the retirement date of the individual. And the second one is the size of the employer group. Because what is happening now is people are working past age 65. And if they're still working under a company insurance plan, that doesn't always, but can become the primary. And in this case, not all those questions were filled out, and Stephanie got on top of it right away. And then we spent 2 full days kind of going through everybody, but everybody listened a little better after that, didn't they, Stephanie? So, all right. So MSP audit is number one. Physician certs, number one, of things that are easy. They can do these long distance. They do not have to be on site to do these audits, and they can take back significant dollars. The MSP, the fine is based on the percentage they fine, so it's not as set. Remember, physician certs are an automatic, it's a technical denial, so you cannot appeal it. So if they find that something's not complete on the physician cert, they just take back the money. So please pay attention to this. The other thing going on, there are increased state surveys and audits of swing bed programs in different states. I now have a second state that probably by the end of this year will have visited all the swing beds in the state. I have one state that already all their swing bed programs have been visited by a state survey team. You are under long-term care, skilled nursing regulations. That means you are in fact supposed to be surveyed. It's just that they have not done swing beds in critical access. They've they've paid more attention, I think, to rural hospitals because of the MDS being filed. So they are doing those now. The primary areas shouldn't surprise you because those are primary areas that we're all, regardless of your setting, we should be paying attention to. Infection control and prevention. There's the emergency preparedness. We're already getting a lot of survey issues on, and I just handed you the document that went into, well, I think it officially went in on, I think it was April 16th, but meantime, they've been updating it. Your interdisciplinary team compliance documentation, I can't say that enough, particularly in critical access, because you do not have the MDS to fall back on. The MDS, you can check boxes and get yourself into certain categories. That means you're in skilled level of care. All of yours comes from your documentation. So then your ICD-10 primary code would be reviewed. Why is that the primary code at a skill level? And obviously physician documentation. And just to stick with this for right now, currently, and that's the first quarter, so that's March. So we'll be doing another one here in an update. In the next month will be coming out. The 10 most cited FTags. FTags are federal tags. If you know anything about the nursing home industry, they get FTags. They have to do a plan of correction. It gets publicly reported these days on the Nursing Home Compare website. Home Health, which has Oasis, also has one. So when you see the two that have new, that first one is the reporting of COVID at a national level. Then 885 is reporting to residents and families. In other words, letting them know about COVID. Those two were specifically new because of COVID. So it doesn't surprise me they're on this top 10 list. People had trouble, particularly with the National Health Safety Network, getting set up in that. And then the other ones, again, we're talking about infection and quality control and quality care. And that list you should see as those are topics that they might be interested in if they come in to investigate your Swingbed program. Infection prevention was in that top list. Quality of care was in that top list. And so that's infection prevention and control. I think I mentioned last time I've already had one site that got dinged for not having proof that the nurses had been trained in housekeeping prevention, infection prevention, which is stunning. It was a $15,000 fine. I think I'm still waiting to hear. They appealed that. I'm still waiting to hear the results of that. So this is where they're going to monitor your activities and practices regarding infection, your training. They're going to go back and look at who you trained and how often you are retraining them. So make sure you're up to date on all that. And quality of care is coming down to resident-centered care. And so that's not new. I think we've been trying to change that language for the last 18, 19 months. What really is important is that your resident representative, in your case, your patient or patient representative, must be, let's put it that way, must be in your IDT meetings, at least have the opportunity to participate. If they choose not to, you need to document that well, because that's part of them having control of the goals, or at least you being aware of what their goals might be. So readiness for this, another one of my signs. This one town had like 20 street signs that I had fun. I ended up spending every evening running around finding their street signs, but I've never seen a 5.5 street before, so I thought it was kind of cool. So readiness is don't sit on 5, go to 5.5 and be ready for what's coming in the door. So some of this will have some repetitive information, and if it's repetitive, it's because it's really important. So looking at your charting, making sure that you have an H&P that's updated, signed, and dated on the charted admission, reminding you that there must be nursing documentation at least once every 24 hours that is showing the ongoing need for skilled. In other words, what are the skilled services that nursing is doing to keep somebody inpatient? The importance of this has come out even more and more, even if they are a rehab primary patient. Remember, therapy only has to see 5 of 7 days. And so CMS, and probably rightfully, is questioning if therapy is not 7 days a week, that means nursing is the service that Medicare is paying for 7 days a week. And they want to see what skilled services they're paying for. Because the alternative is if the nursing isn't there for 7 days, 24 hours, they're going to say, why couldn't this person have gone to outpatient therapy or gone to home health? So nursing documentation is really getting reviewed heavily. I believe that you should have a note once every 12 hours if you're on 12-hour shifts, because I've seen codes and all sorts of things happen that have kept somebody from writing that note, and if they only have the one in the 24 hours. The therapy eval and re-eval, you need to remember that that's your plan of care that must always be signed and dated by a provider. It's not the eval that's getting signed off on, it's your plan of care that the physician or provider is approving. So that is something they will look at pretty quickly. And then physician documentation. You want to have some kind of note, whether it's, at admission, whether it's a progress note during the stay. You want to make sure that that documentation supports skilled level of care. And I'm finding in most swingbed programs, we're having to kind of give examples and teach physicians what to write. Remember, they're there for acute. That's, you're a hospital-based service primarily that happens to be doing some skilled care. And the last one is just a reminder, this goes to the bill. So that's field 69 on a UB04. That should be where the primary diagnosis is. And when you are doing your self-auditing, you really want to pull in and look at the claim. And there are a couple of fields that you could look at very quickly, but the first one you should be reviewing is to make sure that the primary reason the person was in the skilled program, in your swingbed program, that diagnosis is listed in that what's called a primary or principal field, code field. So make sure you talk to your billing on that. And then as far as documentation, the nursing notes, we've just went over. Therapy logs are the one things that I think we've talked about, practical matter or not. It's a statement that's usually done by social services, in this case, probably your case managers. Just, again, it's a statement as a practical matter that they could not go to a lower level of care, which in this case means home health or outpatient therapy normally. So when we're looking at therapy logs, CMS and state auditors and national surveyors are all used to logs because that has been in the nursing industry forever. I'm not saying you have to have a log, but you must be able to show time in, time out, and treatment time, as well as the plan of care provided by a provider if outsiders come in to audit your swingbed program. And so that's actual time. And you see down there a couple of notes down about RT not being in respiratory therapy, not being in 15-minute increments. They don't like rounded numbers. There's actually something in the REI manual that says nothing divisible by 5 should show up. So they don't want 15, 30, 45, 70, 75, whatever. They want 39 minutes, 22 minutes, whatever the actual time is. The only way you can prove that is time in, time out, and treatment time. And then they will be looking at, and we've talked about this, I think we're going to talk about this several times this year, you really need for this short instance in time, looking at the primary therapy documentation and second shift nursing. You can do it by reviewing just one day on a chart. And so if therapy's walking somebody 100 feet and thinks the person's ready to go home, and at night it's a one-person assist to standing and one-person assist to the bathroom, whatever's going on, there's usually some variances there, and that's what we should be talking about in our IDT meetings. But you need to be looking at that documentation between those two levels right now, because that's an easy area, again, for outsiders to hone in on to say, how did we make our decisions for the length of stay we had and when somebody was going home. You do need physician progress notes or provider progress notes that discuss that primary diagnosis that's putting them in a skilled setting. Obviously, discharge planning, we've talked about it, and Becky did some homework for you on the ombudsman in the state of Indiana. So we do need to make sure that you have documentation that shows that you have involved the ombudsman where it's needed, and then IDT notes. They're looking for sign notes, and some of you have computer programs, software programs that are not allowing you to sign. So you just need to figure out how you're going to address that. I don't know that there's one right way to do it, but you need to be able to prove who was in the room. And the current regulation, I think, was interrupted, and by now we would have had it change, but there is somewhere in the regulation about 30 pages into it that says that you must offer the patient the opportunity to sign off on the IDT. if you can, I think it's preferred that you get the patient or patient representative to sign it, because I don't know any other way you can prove that you really did listen to the patient goals unless that signature is there. But it is not required at this moment in time. So IDT, again, those participants that are required by federal law are listed there. We've talked about them. They expect from the last 6 months of comments from CMS have talked about, that's where our baseline care plan should be updated, because most of us are still keeping patients 20 days or less. So we're sticking to that baseline care plan. It should be updated. Patient goals should be documented, included in that plan. And then again, the meeting notes need to be completed and signed off by your team. So to keep you in the compliance mode now, because I do think we're going to have more reviews and audits, there is a triple check process that nursing homes have used, and it's fairly lengthy. And so you can choose to do this on 1 or 2 initially, and if everything's okay, maybe not keep it up. If you find some issues, you might want to just check for those issues on all of your discharging or prior to discharging patients from Swingbed. Nursing homes tend to do this on all of their discharge Part A's before they submit a claim. So it's up to you to decide what the system should be. Depends on how comfortable you are. And in the handouts, you will see a triple check form that I've included. And the only thing that you will have to pay attention to is where it says something about the MDS. Obviously, critical access, you don't have the MDS, but you need to see where that is documented in your system. So, if it's your Medicare card, for instance, or if it's this or it's that, you need to know where in your charts, because it's not just clinical charts. Remember, some of these are business charts and or billing charts at the end. So we need to make sure that you are reviewing it. So it is a self-audit. I am going to strongly suggest that everybody should be self-auditing at least a portion of your discharging swing bed patients until you feel comfortable that you have it under control. Because you saw that list with a number of auditors that are potentially out there. I would hate to have all this work to build up a good swing bed program and then have money taken back because we didn't check ourselves to make sure everything was signed, sealed, and delivered the way that the government expects it. Prior to submission, again, you do not have to do the MDS. But you should be looking at your documentation to the claim, and they should match as far as the primary diagnosis codes. Don't worry about ARD. That's a reference date again for the MDS. If any of you are in a rural hospital, that would apply to you. But occurrence dates and that sort of thing on the claim. So you need to take a chart and a claim and sit down as a team and at least go through one so you see how it flows. And the best way, I think, is to get the running list of all the services that were provided to the patient and have clinical and billing people look at that to make sure everything's accurate. So I think with that, Becky, that's sort of our list of things for today. That's what the triple check form looks like, and I'll see if I can find it. So there's your MSP to go back to what we were talking about initially. But here where you see MDS, it says documentation that supports it. Well, that includes your chart, therapy notes, and other services. And always, if you have questions now, I'd be glad to try and answer them. If you have questions later, Becky knows where to find me.
Thanks, Kerry. And Kerry and I will stay on just a few minutes if you do have questions, but we ran over a little on time today, but still really good information that was shared. So you're willing to jump off, but if someone does have a question, go ahead, chat it in or unmute your line by clicking on the microphone button by your name in the participant list, and we'll be glad to address a few quick questions right now. So, Kerry, a question that came in was, we are taking non-Medicare patients to our swing bed units. Do you have any recommendations on best practices to make sure that we have everything covered?
Yeah, it would be the same process. You just won't be under the Medicare A reviews, but as you know, managed care reviews a lot. So I would be doing the chart review to that claim review. And what you would have to take into consideration is, I don't know if it's United, UHC or whoever it might be, you would want your billing and coding people to tell you what they think are the reviews coming from that particular insurance company, because all of them have slightly different reviews going on. But that same process, this form that you have here could be adapted to that too, because it's still matching up key documentation to the claim. So I would work with your billing department and see what they're hearing of things that are getting reviewed, and then I would be looking at your documentation to that claim.
Okay, thank you. Any other quick questions before we sign off? Glad to address them. And I'll just pause here for a minute. Any update on the PHE, Kerry?
Yeah, PHE is supposed to be re-signed on July 20th. You remember, it's only in place for a number of months, and then it has to be re-signed. There is no discussion out of Washington now that it's not going to be re-signed, and I think we would have heard rumors of that. And since I'm in one of those hot states now for the D variant, I think because D is on the increase so much, they will re-sign it. The expectation has been for months that it would be probably around the end of the year when they don't re-sign it. In other words, the PHE ends. What PHE is, Public Health Emergency, if you don't know the acronym. In the meantime, those that have impacted you, like 3-day waiver, they're in place right now. As soon as we see that July 20 has been signed, then I'll be getting that information to Becky, and Becky will probably see it also from the state. So we'll get that information out to you. But the expectation now is that it's going to continue. So if it's re-signed July 20th, that gives us 3 months for sure, more after that.
Thanks, Kerry. And Zach for asking that question. That is something that I've received questions on a couple of times this past week. So since we're getting so close to the deadline.
Yeah, this is a little closer than we've had in the past. I'm not sure why, except they're just settling into all the things that are going on, health-wise. And again, all the variations and all the vaccines, all that information they've spent a lot of time on. But I've just heard nothing. In fact, all of us have been talking about it because we've heard nothing that says it won't be signed. No hint that direction. And I think the federal law, I don't know if it applies to this one, but I know going forward after this, the federal law says we have to have 60 days notice before they can just drop the bomb on us. So I think the reason we're all kind of hesitating right now is we're not sure this date applies to a federal law that just came into effect. But from there on, we're supposed to have 60 days heads up that it will be changing.
Okay, I'm not seeing any other questions in chat. Again, always reach out. We did record today's session. I'll be sending out the recording link along with the handouts that are associated with it. So feel free to forward that on to other individuals in the organization that you believe would find the information helpful. Thank you so much, Kerry, and have a great day, everyone. Bye-bye.
Bye. Bye.